Hi, I'm Nikki Liburd, one of the OBHG hospitalists. I'm actually a site director at one of our locations here in California. Today, I'd like to highlight a couple of areas that myself and others as OB hospitalists do to serve the community, our patients, and the hospital. So one of our roles is to actually serve as a safety net for patients who come in that don't actually have not actually established care with a provider. So one night on my call, a woman came in. This is her fourth pregnancy, and she came in with a term pregnancy, meaning 39 weeks, and she was in early labor. It's my responsibility primarily to take care of these patients who don't either have care or have very little care with a provider, and just give them quality care. So when she came in, I started what was called an induction of labor, getting her into labor because she was in early labor and her water broke. So during the course of the night, it was pretty interesting. The patient actually had a substance abuse problem. She used heroin and other drugs and explained that was part of the reason why she didn't seek care earlier. But because her water broke, she decided to seek care. We were very appreciative of that, not only because of, not seeking care for the reasons of using drugs, but also because she was homeless. Okay, so very unique patient. She had a lot of challenges going on in her life, but she still presented for care, and that's what we were going to give her. So over the course of the night, she progressed in labor, and at the end of my shift, she was actually almost complete. Okay. At the end of our shifts, usually because we're at a part-time program, we sign out any patients that we were taking care of to one of the community obstetricians in the area. That morning, there was a problem with communication getting a hold of the person who was going to take over for us. Luckily, though, I was there to serve another role that OB hospitalists can also do to provide service. We were doing an OB simulation drill test run, okay? And what simulations are is a way for staff, including physicians, nurses, and other medical staff, to practice a scenario, or that is usually an OB emergency. Okay, and then later on present it to an audience for learning purposes. So we were having our first practice session right after my call ended, which is around 7:05 the next morning. As you heard, I wasn't able to get in contact with the community physician who was taking over. However, I was close by, I was on the ward. And then we heard a cry from one of the from the labor room that my patient was in, from the nurse, saying that she's pushing, she's complete. However, the baby's heart rate was down, and now it's been down for at least 2 minutes. This is an emergency. I was kind of in shock when she told me that. I didn't expect her to start pushing and the baby, of course, to have problems with its heart rate. So myself and another OB hospitalist who were practicing the drill that day ran into the room, assessed the situation. Even though the heart rate was down, the baby was well into being delivered any second. However, and we asked her to push. She tried her best, but it wasn't enough. And the tracing was still showing that the baby was in distress. So then I made the call to bring the patient immediately to the operating room for likely an emergency cesarean section. At our hospital, it's a community hospital, so not all of the medical staff are there immediately to assist, such as the anesthesiologist, who is on call, dedicated for our department, but takes home call. And other physicians also weren't there. However, we did have nursing. Nursing staff actually signed out a few minutes before I left my shift. So, hey, we had enough of people. However, we did definitely need the anesthesiologist. So it took us a minute to get to the back, but, we did it actually in a timely manner. Okay. And during that time, the anesthesiologist was notified. They were unable to reach that person. But guess what? There was a case going on in the main operating room, and the anesthesiologist for that case was wrapping up, heard that they needed someone, and came right up and served as our anesthesiologist for this case. While we're in the operating room, I made one final attempt with the patient to see if she can push, because it seemed like the baby's head was coming down and delivery would be imminent. However, she had a hard time pushing. So during that time, we were able, however, to get the baby's heart rate up right after she tried a second push. And that gave us enough time for the anesthesiologist to provide regional anesthesia, in this case, a spinal. So after that, we tried one more time to see probably if it could have been just a problem with pain for the patient, and that's why she was scared to push. Well, she was unable to push effectively. By that time, the heart rate went down again. So I knew something was definitely not only wrong, but then I also felt, well, hey, we need to move forward with the next step. So my OB hospitalist colleague and I did an emergency cesarean section. What that means is you get the baby out very quick, like within a minute usually, and that's what we did. The baby did well, actually, came out screaming and crying. Okay. After the operation, I talked with the patient. She was very grateful for her care, even though it was a pretty scary thing to have to go through. She was very grateful, and we were very grateful that she presented to us for help.